Good evening, everyone. I am Dr. Ravi Teja. I am infectious diseases physician. So today we are going to discuss one important disease, one important clinical syndrome, which is hand, foot, and mouth disease called HFMD. So hand, foot, mouth disease is a clinical syndrome characterized by oral ananthem and a maculopapular or vesicular rash of the hands and feet. So it's a clinical syndrome. So ananthem means involving the oral mucosal surfaces. So it involves the mucosal surfaces and also the skin in the form of maculopapular or vesicular rash, most commonly involving the hand, feet. So hence it is called hands, foot, and mouth disease. So it is the most recognizable viral exanthem in children and adults. So it is the most common in children and adults. So it is the most common viral infection seen in this age group. So what causes this hand, foot, and mouth disease? So it is a viral infection caused by enterovirus genus group of viruses. So it is a RNA virus belonging to the picornavirus family, and the genus is enterovirus, and there are many species in the family of enterovirus which cause this HFMD disease. Basically, it is a RNA virus. It is caused by Coxsackie virus A16, most commonly Coxsackie virus A16, and also enterovirus A71. So this Coxsackie virus A16 and it is Coxsackie virus A serotypes, which includes many serotypes. One of the most common serotype is A16, and also enterovirus A71 is also one of the important species in the enterovirus family. So these two are the most common viruses in the enterovirus family which cause HFMD. So please only remember these two Coxsackie A serotypes. Most common is Coxsackie A16 followed by enterovirus A71. So if anyone asks HFMD, hand, foot, and mouth disease caused by, if I ask you, so you have to tell Coxsackie A16 and enterovirus A71. All are RNA viruses. And there is another syndrome called Herpangina. It is also caused by enterovirus genus group of viruses, and it is also a benign clinical syndrome of fever, painful papulo-vesiculo-ulcerative oral ananthem, and it is also caused by Coxsackie A serotypes. So just both are different clinical syndromes, but caused by same group of enterovirus family. Just the clinical presentation is different and viruses serotypes are different. One is HFMD and the other is Herpangina. So coming to the pathogenesis, so how does one child or adolescent acquire HFMD? So most commonly it is the fecal-oral route of transmission. So if any child, generally child spreads through respiratory or oral secretions or from the gastrointestinal secretions. So infection occurs through oral ingestion of the virus that is shed from the GI or upper respiratory tract of infected individuals, or may occur following contact with vesicle fluid or oral and respiratory secretions. So oral secretions, respiratory secretions, gastrointestinal secretions, or the vesicle fluid. If any child comes in contact with other child with vesicles, ruptured vesicles, that fluid is also infective. So these are the various routes of transmission from one child to another child. And how will you differentiate in the pathogenesis? How will you differentiate from other vesicular diseases? So if you do a light microscopy of the biopsies of the skin lesions or scrapings of the base of the vesicles, they do not demonstrate nuclear inclusion bodies or multinucleate gain cells, which are commonly present in chickenpox or herpes simplex virus vesicular diseases. So these HFMD, herpangina vesicles do not show multinucleate gain cells, do not show intranuclear inclusion bodies on microscopy. That is one of the pathological difference. Next, coming to epidemiology. So HFMD can occur at any age. However, most cases occur in infants and children less than 7-year-old, but they're also described in children more than 7 years and adolescents and adults also. But most common age group is infants and children less than 7 years of age. And incubation period disease, we have to know the incubation period. Incubation period is 3 to 5 days. Coming to the clinical features, so most commonly the child or infant presents with mouth pain or throat pain or refusal to eat. So if it is an infant who is non-verbal yet, so the most common is they refuse to eat, they refuse to drink fluids. That is the symptom. If it is a little elderly child, like more than 1 year child, so they complain with mouth pain or throat pain, and fever might be present, but it is most commonly less than 10 degrees 101 Fahrenheit. And very occasionally prodromal symptoms occur, like along with fever, some fuzziness, abdominal pain, some vomiting, some diarrhea also may be present, but these are less common. The most common presenting symptom is mouth pain or throat pain, or if it is an infant, refusal to eat and drink are the most common symptoms, and fever less than 101 degrees Fahrenheit. So these are the initial presentation of a child or infant. So they will present like you see in this picture, small ulcers are present in the buccal mucosa. These are very small ulcers and typically described as surrounding mild erythematous halo is seen. See, if you see the small erythematous halo on the this around the ulcers in the buccal mucosa, these are very typical of HFMD. And vesicular lesions are also seen. Small ulcers are also seen on the tongue. As you can see in this picture, small vesicular ulcers are also seen. So one of the important, these are the very classical presentation of HFMD oral ananthem. How will you differentiate from herpangina? So the important clinical clue is, so these vesicular ulcers in HFMD are located anterior to the tonsils in the buccal mucosa, whereas in herpangina, these vesicles will be located posteriorly to the tonsils, like atriomolar area or on the soft palate. That is a differentiating point. HFMD will have vesicular ulcers over the buccal mucosa and the tongue, whereas herpangina will have posteriorly to the fauci on the soft palate. That is the important clinical clue. And if it is another clinical clue, it is a herpes simplex gingivitis, they will involve the gingiva. So this HFMD will not be most commonly will not be involving the gingiva and will be present anterior to the tonsils in the buccal mucosa and the tongue. That is the important clinical clue. And along with the oral mucosa, oral ananthem, skin is also involved. So as you can see in this picture, multiple maculopapillar and vesicular lesions are present in this child involving the foot. So multiple vesicular lesions on an erythematous base are present on the foot. So erythematous base is involved, and there are lesions are present at the same time in various stages, like in chickenpox. But I'm just telling you, but this only involves the hands and feet. So macules, papules, and vesicles on erythematous base. So multiple stages, various stages of lesions are present at the same time. Mostly they are non-puritic, and usually they are not painful, and they usually resolve in 3 to 5 days. This is of typical hand, foot, mouth disease. Incubation period 3 to 5 days, oral ananthem, and skin exanthem. Please remember these important points. And HFMD, as I have told you before, it is also caused by another enterovirus called enterovirus A71. And this causes severe illnesses. So this enterovirus A71 has been associated with severe illness, which is complicated by central nervous system disease. Like it can cause thromboencephalitis, acute flaccid paralysis, aseptic meningitis, pulmonary edema, and pulmonary hemorrhage and heart failure in certain children infected with this enterovirus A71 serotype. It is a complication by this virus. And another virus, Coxsackie A6, is also another enterovirus which can cause HFMD. So it presents, it is a atypical HFMD. So generally fever will be less than 101 degrees Fahrenheit as we discussed, but A6 serotype causes high fever. And wider distribution of the lesions, like involves the whole extremities, upper thighs, buttocks, arms, can also involve the face, lips, perioral area, buttocks, groin, perineum. So wider distribution of lesions will be there, and more extensive skin involvement will be there in the form of vesiculobullous lesions, bullae, erosions, ulcerations, and eschar formation is also seen in some rare cases. And the longer duration of this, all the skin lesions will be there. Generally, it is all in 3 to 5 days, but this atypical HFMD caused by Coxsackie A6, the mean duration of will be there 12 days. And at times they can also lead to palmar and plantar disformation 1 to 3 weeks after HFMD. So this is a atypical HFMD. Commonly HFMD resolves in 3 to 5 days, maximum 1 week, mild illness. But HFMD caused by Coxsackie A6 is called as atypical HFMD, where symptoms and signs will be more. Just remember like that. So how will you diagnose? So diagnosis is by identification or isolation of enterovirus from the vesicular fluid. So children will have these vesicles. So if you have doubt, most of the time it is a clinical diagnosis. But if you are unable to differentiate from other clinical infections, so the vesicle PCR can be done, which helps in diagnosis. So isolation or identification of the enterovirus from vesicular fluid, or if it is a typical HFMD or a complicated HFMD, you can also isolate the virus from the cerebrospinal fluid. If the child has septic meningitis or thromboencephalitis, the CSF can be tested by enterovirus PCR, and we can diagnose, confirm the etiology of HFMD. And identification or isolation of enterovirus from the stool or throat does not definitely establish causality. So this is a very important point. Many children will also shed the virus asymptomatically in the oral secretions, the respiratory secretions, in the gastrointestinal secretions, in the stool. So an asymptomatic child can also shed the virus in the the respiratory secretions, oral secretion, and the stool. So identifying enterovirus in the stool PCR will not tell the child is having disease. He might be shedding asymptomatically. Okay, so that is a very important point. So just identifying the PCR will not help you diagnose the disease. Clinical symptoms should be there, clinical signs should be there. Then only you can confirm that this is the pathogen. Like I have said, following acute infection also, if any child develops HFMD, the viruses can shed for many weeks, both in the respiratory and the stool secretions. So enterovirus shed from the stool and throat for prolonged periods, to 6 weeks to several months, and up to 4 weeks respectively. Stool, it can shed until several months, up to 12 weeks also, and the respiratory up to 4 weeks. So just identifying the PCR in the stool or respiratory secretions will not help us in the diagnosis. Clinical signs and symptoms also have to be taken into consideration. And the isolated virus may or may not be responsible for the current symptoms. So the child may be completely asymptomatic. He might be shedding the virus in the respiratory and the gastrointestinal secretions. Okay, that is the important point. So what are the differential diagnosis? So the child presents with vesicular lesions in the buccal mucosa, in the on the tongue, on the throat. Many vesicular maculopapular lesions will be there on the feet, on the hands. So it is, we have to be observe the child very carefully and ask the history very carefully. Then only we can diagnose, because it is a clinical diagnosis. So what are the other differential diagnoses? So one important is primary HSV gingivostomatitis. So as I have said to you earlier, HSV gingivostomatitis, the HSV vesicles will be involving the gingivostomatal area, gingivobuccal area. So, but HFMD does not, most commonly does not involve the gingival areas. Aphthous ulcers, it's a very most common. Aphthous ulcers are also seen. One of the differential diagnosis. And erythema multiforme also presents in a similar manner. Varicella is the most common infection, viral infection in children. So, but how will you differentiate? So, varicella, same macular, vesicular lesions. All lesions at same stage will be present, but is a generalized vesicular rash. Starts on the face and spreads to the trunk. HFMD, only hands, feet, and mouth. Chickenpox, varicella, from face to trunk. So that is a important clinical differentiation. Contact dermatitis, also one of the important differential diagnosis. Mpox can also present in a similar manner. So you have to carefully ask the history. When did the symptoms develop? What is the progression of symptoms? And what are the stages of all the skin lesions? What are the associated symptoms? All these have to be taken into consideration in the diagnosis. Most of them all are clinical diagnosis. You can't just do one test and diagnose after ulcers, or do one test and diagnose varicella. All these are clinical diagnosis. So careful history and examination are very important to diagnose these conditions and differentiate from other conditions. Okay, so if varicella is there, you can give cyclovir or valacyclovir, but HFMD there is no treatment. So that is a very important point. So differentiating one illness from other illness is very important, because treatment is there for certain infections. Certain infections treatment is not there, only supportive treatment. So as I have told you before, hand, foot, mouth disease and herpangina both are caused by enterovirus genus. So hand, foot, mouth disease, Coxsackie A16 is the most common virus, followed by enterovirus A71, and Coxsackie A6 also is there. And herpangina, also same enterovirus genus causing this infection. Most common is Coxsackie A1 to A6, A8 and A10. So viruses are same, but the clinical presentation is different. Just remember these two syndromes. Management. Management is mainly supportive. And children with complications, like I have told, like atypical HFMD or complications may require hospitalization. Complications include aseptic meningitis, pleuritis, or any pulmonary edema or encephalitis. So all these complications, children may require hospitalization, and there are no specific antiviral therapy is available for the treatment of enterovirus. It is mainly supportive management. You take care of the fever, you take care of the hydration, it will resolve. Typical HFMD will resolve in a week time. Atypical HFMD and HFMD with complications, you may need to hospitalize the child and take care of all the complications. But there is no specific antiviral therapy. HFMD is generally a mild disease, a self-limited illness that resolves in 7 to 10 days, maximum 10 days. And how will you prevent? As I have told you, children asymptomatically also will shed the virus in the respiratory secretions, in the gastrointestinal secretions. So daycare centers or in very classes. So asymptomatic child will spread the virus to other child and he might develop disease. That child may not have disease, but he might be just shedding the virus in the respiratory and gastrointestinal secretions, which leads to the infection in other child and he may develop disease HFMD. So how to prevent this? So one of the most important thing is strict adherence to hand hygiene protocols is important when changing diapers because enterovirus are shed in the stool for weeks following infection. As I have told, viruses are shed in the stool for many weeks, up to 12 weeks. So whenever we have 2 3 children in nursing home or in the daycare area, the children or caretakers, when changing diaper they have to follow strict hand hygiene so that to prevent spread of infection from one child to other child. Thank you. So please remember this very important clinical syndrome of HFMD and caused by enteroviruses. Most common Coxsackie A16 and enterovirus A71, most common in children and adolescents and infants. It's a clinical diagnosis. Most commonly is a self-limiting illness. Maximum in 10 days it will resolve. In certain children, they may develop complications like meningitis, encephalitis, pulmonary edema, or acute flaccid paralysis. So certain children will develop complications. So carefully ask the history and do appropriate clinical examination to identify this clinical condition. Thank you.